right, let's jump right into this high-yield review of Clostridium tetani. Look, if you're an MBBS student prepping for your microbiology or clinical exams, you're in the exact right place. We're going to break down this kind of intimidating bug into a perfectly structured explainer, basically designed to help you completely crush your MCQs and short answer questions. Let's get into it. So here's our roadmap. We're hitting the introduction, pathogenesis, clinical features and complications, lab diagnosis, treatment and vaccines, and wrapping up with neonatal tetanus. Section 1, Introduction. Let's hit the basics. So what exactly are we dealing with here? Well, Clostridium tetani is an obligate anaerobic gram-positive bacillus. Now, obligate anaerobic, as you know, means it literally cannot survive in oxygen. It needs an oxygen-free zone to multiply. But hey, the absolutely high-steeled buzzword for your exams here is its characteristic terminal round spore. This is what gives the bacteria that classic drumstick appearance under a microscope. If an examiner ever asks you about a bug that looks like a drumstick, boom, you immediately know it's Clostridium tetani. Also keep in mind it's ubiquitous, meaning it's found everywhere, especially hanging out in the dirt and soil. Moving right along to Section 2, Pathogenesis. Let's see how this disease actually develops. Okay, it's actually surprisingly easy to tell the two main exotoxins apart using the L and S memory trick. Tetanolysin starts with an L, and it lyses red blood cells. But here's the catch. It has basically no role in the actual pathogenesis of clinical tetanus. The real troublemaker is Tetanospasmin. S is for spasms. This is the plasmid-coated neurotoxin that causes the actual severe spastic disease. All of our clinical focus, it's entirely on tetanospasmin. Now, if you get a short answer question on the mechanism of action, you're going to want to reproduce this exact four-step cascade. Once the bacteria multiplies in a nice, oxygen-depleted wound, it pumps out tetanospasmin. Step 1. The toxin binds right to the motor nerve terminals. Step 2. It doesn't just stay there, it actually travels backwards. We call this retrograde transport, all the way up to the inhibitory neuron terminals in the central nervous system. Step 3 is the absolute game changer. It blocks the presynaptic release of inhibitory neurotransmitters, specifically GABA and Glycine. I mean, think about it. If you literally cut the brakes on your nervous system, what's going to happen? Well, step 4, you get unchecked continuous excitatory firing, leading to massive spastic muscle contraction. So how does this ubiquitous soil bug actually get inside us? Well, you can easily recall the modes of transmission using the simple acronym SANI. S is for surgery done without proper asepsis. O is for otitis media, which can trigger otogenic tetanus. N is for neonates, usually from unhygienic practices around the umbilical stump. And I is for injury. Think road traffic accidents where a wound gets packed with contaminated soil. Remember, the wound itself provides that perfect, reduced anaerobic environment for the spores to wake up and germinate. Section 3, Clinical Features and Complications. Let's look at the signs and the progression of the disease. When we look at the timeline, the incubation period is typically 6 to 10 days, and you should definitely mark down in your notes that a shorter incubation period means a much graver prognosis. The very first symptom is usually a spike in masseter muscle tone, causing trismus, which we all know as lockjaw. Why the jaw first? Simple. The toxin just has a shorter distance to travel to reach those specific presynaptic terminals. Over the next few days, this evolves into a terrifying descending spastic paralysis. By the second week, severe autonomic disturbances kick in. We're talking wild, erratic blood pressure and tachycardia. And here is a crucial, heartbreaking clinical pearl. Throughout all of these horrific muscle spasms, the patient's mentation remains completely unimpaired. They're entirely awake through the whole ordeal. You can lock these classic, highly testable complications right into your memory with the TRO acronym. T is for trismus, that lockjaw we just talked about. R is for Risus sardonicus. This is a sustained facial muscle spasm that basically forces the patient's face into a fixed, unnatural grin. O is for opisthotonus. This is a profound, generalized spastic contraction of the extensor muscles that forces the patient's whole body to arch backward into a really extreme extended posture. And please never forget the ultimate fatal complication here, respiratory muscle spasm, that literally leads to total airway obstruction. Section 4, Laboratory Diagnosis. Time to figure out how we confirm this in the lab.
Now, while clinical diagnosis dictates that you start treatment immediately, examiners absolutely love to test the differences between laboratory culture media. If you inoculate Robertson cooked meat broth, Clostridium tetani, since it's a proteolytic bacteria, will digest the proteins. This turns the meat particles black and kicks off a very distinct foul odor. Contrast that with blood agar containing polymyxin B, incubated anaerobically. On that one, you're going to see characteristic swarming growth and hemolytic colonies, and that's thanks to that tenolysine we mentioned earlier.
Because the pathogenesis is entirely driven by the toxin, just growing the bug isn't always enough, right? We have to prove it's actually producing toxin. We do this with toxogenicity tests. In vitro, we apply an antitoxin to half of a blood agar plate. If hemolysis is prevented on that specific side, boom, it proves the toxin is present and being neutralized. Alternatively, we have the in vivo test, which involves inoculating the culture into a mouse's tail. If that mouse develops visible tail spasms within 24 hours, you've officially confirmed the presence of the Tetanospasmin neurotoxin.
Section 5. Vaccines and Treatment. Let's talk immunization and patient care. When treating clinical tetanus, always remember this. Passive immunization is your primary, immediate go-to treatment. We use human tetanus immunoglobulin, or HTIG, at 250 international units. It lasts for 30 days and is heavily preferred over the older equine-derived ATS, which carries a pretty high risk of serum sickness. Now, you might be wondering, what about antibiotics? Well, metronidazole is the drug of choice, but it plays a surprisingly minor role. Why? Because antibiotics only kill the bacteria to stop new toxin from being released. They do absolutely nothing to neutralize the toxins that are already locked onto the nervous system. So they're really only useful in very early infection, typically under 6 hours.
Okay, you absolutely must memorize this algorithm for wound management. It is practically guaranteed to show up as a clinical scenario question. If a patient comes in with a wound, your decision hinges on two things. Is the wound tetanus prone, and what's their immunization history? If they had their vaccine within the last 5 years, do nothing. They are completely safe. If it's been between 5 and 10 years, you give 1 booster dose of TEAD, regardless of the wound type. But pay close attention to the bottom 2 rows. If it's been more than 10 years or their status is unknown and they have a dirty tetanus-prone wound, you have to give the active vaccine plus the passive HTIG immunoglobulin to give them that immediate protection.
Section 6. Neonatal tetanus. A highly testable short note on the 8th-day disease. This right here illustrates the tragic reality of the disease. This neonate is suffering from severe epistetonus, that generalized spastic contraction of the extensor muscles we talked about earlier. It causes the entire tiny body to rigidly arch backward. It's a devastating presentation that usually kicks in after the first week of life. So for a perfect short note, make sure you hit these key points. Neonatal tetanus is historically known as the 8th-day disease. The WHO actually defines it as occurring when a child loses the ability to suck and cry between days 3 and 28 of life, becoming incredibly rigid with spasms. It's almost entirely caused by unhygienic delivery practices like getting an infected umbilical stump. Prevention here is entirely focused on the cleans: clean hands, clean surface, clean blade, clean ties, stump, towel, and clean water. And here is a fantastic fact to conclude your note with. Through aggressive vaccination of pregnant mothers and massively improved delivery practices, India officially achieved the complete elimination of neonatal tetanus as declared by the WHO back in 2016. Before we wrap up this explainer, let's do a super quick pop quiz to see what stuck. Do you remember which specific exotoxin binds to the motor nerves and blocks the release of the inhibitory neurotransmitters GABA and Glycine? And what is the specific antibiotic of choice if you happen to catch the infection within the first few hours? Think back to our L&S rule and our treatment protocols. I'll leave you to ponder that. Tetanus is just a stark, crazy reminder of how a microscopic spore hiding in the dirt can completely hijack the human nervous system, and exactly why global vaccination remains one of our absolute greatest medical triumphs. So, what other hidden dangers are lurking right beneath our feet? Keep studying hard and stay curious.